Continuing with Chapter 46, we're going to discuss Part 2, Disorders of the Pancreatic Function. First one we're going to talk about is type 1 diabetes. Diabetes mellitus is the most common metabolic disease in children. Peak incidence between 10 and 15 years of age. More prominent in Caucasian. Most children have type 1, although type 2 is on the rise. So, how do children get this? Well, it can be an autoimmune response, such as genetic or environmental trigger or viral infection. It could be beta cells of the pancreas are destroyed. It could be little to no insulin, which is produced by the body. Lifelong insulin replacement will be needed. You want to look at Table 46-1 on page 1477 of your textbook. Usually occurs in school-age children and it can occur in infancy. It's diagnosed by random blood sugars of greater than 200 or fasting 8-hour blood sugar of greater than 126 or a blood sugar of 200 at the 2-hour mark of an oral glucose tolerance test and the other classic signs of diabetes. So some of the signs and symptoms are the polydipsia, the polyuria, the enuresis, weight loss despite voracious appetite. There could be glycosuria, abdominal complaints, nausea, vomiting, metabolic acidosis. Look at box 46-13 on page 1478 of your textbook. Therapeutic management, insulin therapy. There's going to be a multidisciplinary approach. We talked about insulin therapy is going to be needed. You're going to do glucose, have the patients and the parents do glucose monitoring. Goal is to be near normal levels of less than 126. Laboratory measurement of hemoglobin A1C. Goal should be less than or equal to 7. Glycerin control. You want to have decreases the risk of long-term complications. So what does insulin do? Well, what it does is it pushes the glucose in the bloodstream into the cells, and then when serum glucose levels get too high, then the excess is spilled over into the urine. Cells break down protein for conversion to glucose by the liver, such as glucogenesis. So there are methods of insulin delivery. It could be subcutaneous injections or an insulin pump. The type of insulins, you should be familiar with these. These are the rapid acting, like within 15 minutes. Short acting within 30, intermediate acting 2 to 6 hours, and then long acting 6 to 14 hours. You may need to refresh your memory on these. Look at box 46-14 on page 1480. Remember, stress, illness, and infection can either decrease or increase insulin needs. Let's continue with therapeutic management. So nutrition needs are the same for all children. Concentrated sweets are discouraged. You want to teach parents meal planning. Exercise should be encouraged. You want to educate parents on providing child with extra snacks during time of exercise and plan ahead if possible. Morning measurement for hyperglycemia to assist with maintaining blood glucose levels is needed. You want to teach them about illness management. The goal of illness management is to maintain control of blood glucose. Child may need supplemental insulin between doses. You want to teach them about recognition and treatment of hypoglycemia and hyperglycemia. It's very important. You want to be sure to teach parents the signs and symptoms and how to treat. Teach them to do record keeping. It's very essential. They can keep track of their blood sugars. Educate the parents to keep the record of all symptoms, the levels, the glucose levels, insulin administrations, and any interventions they may have implemented. Self-management is very important for these kids. They should be taught how to check their blood glucose levels as well as how to self-administer insulin as soon as possible. You want to provide family support. Provide the parents with the resources and refer them to the American Diabetic Association and National Institute of Diabetes and Digestive and Kidney Disease organizations. So let's kind of review the nursing care. Educate about the disease. Provide treatment and management of disease. Teach about insulin administration, dietary management, exercise, and blood glucose monitoring, the signs and symptoms of hyperglycemia and hypoglycemia. You should also be aware of these if they are in the hospital. Children should wear a medic alert bracelet. School aged children should be responsible for as much of their own healthcare management as possible. Parents should alert the school nurse and keep the school nurse updated on the child's condition. If they're in the hospital, you're going to monitor blood sugars, the hemoglobin A1C, the intake and output. You're going to watch them hydration. You're going to promote nutrition. You're going to monitor electrolytes. So look at your nursing care plan on page 1484 and 1485 of your textbook. Okay, everyone, remember what a diabetic ketoacidosis is? This is a pediatric emergency. It results from progressive deterioration with dehydration, electrolyte imbalance, acidosis, coma, and can even cause death. When glucose is unavailable for cellular metabolism, the body breaks down alternative sources of energy. Ketones are released, and the excess ketones are eliminated in the urine or by the lungs. That's where you get the acetone breath. Ketones in the blood are strong acids that lower the serum pH and produce ketoacidosis. Management, a diabetic ketoacidosis requires rapid assessment, adequate insulin to reduce elevated blood glucose levels, and fluids to treat dehydration and replace electrolytes. The child should be in ICU. You want to place the child on a cardiac monitor. You want to possibly they're going to need oxygen. You're going to start a normal saline bolus and an insulin drip. Then glucose is added to the IV fluid. You place the child on the monitor because once you start rehydrating them, the potassium will be driven back into the cells, which leaves the serum seriously depleted. So watch the EKG strip on the monitor for a widened QT interval or an appearance of a U wave followed by a flattened T wave, which indicates hypokalemia, and a spreading T wave and shortened QT interval, which indicates hyperkalemia. Basically, any waveform changes indicate that something is going on with the potassium, and as a nurse, your job is to report that to the doctor immediately. As soon as the child is rehydrated, then aggressive potassium replacement is given. After the initial fluid bolus is in, insulin is started because glucose levels fall after volume expansion. If you start it before you rehydrate, you are likely to give them too much insulin. Once the levels fall to 250 to 300, then you add some glucose to the IV fluids to maintain a glucose level of 120 to 240. Sodium bicarb is used to treat a pH that is less than 7. Severe hyperkalemia or cardiac instability. The goal is not to have to use the sodium bicarb because there is an increased risk for cerebral edema with this. If it is used, then you must monitor for changes in level of consciousness. Let's talk about type 2 diabetes. It arises because of insulin resistance caused by insulin deficiency or more commonly because of decreased insulin receptors. Onset is usually after the age of 45. It can be potential in pediatric patients though. Usually occurs Native American, Hispanic, African American children, or even Caucasians. There is an increased risk for type 2 diabetes mellitus. It affects people that they may actually end up needing insulin injections. Major risk factors, manifestations can be such as obesity, high fat diet, family history, not enough exercise. Testing a non fasting blood sugar of greater than 200 is an indication. Okay, let's talk about some long term complications. Microvascular changes begin in usually the first 30 years of the disease, usually within the first 10 to 15 years after puberty. These include nephropathy, retinopathy, and neuropathy. Macrovascular changes result from glycosylation, and basically what happens is the vessels get gummed up, which causes impaired circulation and interferes with microcirculation. Macrovascular usually begins after 25 years of age, and this is commonly in type 2. With poor control, vascular changes can occur as early as 2.5 to 3 years after diagnosis. With excellent control of the disease, these changes can be delayed to 20 years. This concludes Chapter 46, Pediatric Endocrine Dysfunction.